Thank you very much for inviting me to this important webinar. And I would be speaking on frailty. And let me begin by sharing the screen so that I could show the presentation. So, so here we go. I hope you are able to see the PPTs. And I would just change it to the slideshow before I begin. So here we go. Frailty is one of the lesser known problem, particularly in old age. So I thought it would be prudent to discuss some basic facts about this disease. Frailty in Oxford Dictionary as a layman's term means an individual who is weak, infirm, fragile, unadorned, or unchaste. In medical terms, it is difficult to define, and the geriatrician is still trying hard to define it. There are several definitions that exist in the medical literature, but this is one of the best definitions, I thought. It is a clinically recognizable state of increased vulnerability resulting from age-associated decline in reserve and function across multiple physiological systems, such that the ability to cope with everyday stressor or any acute stressor is compromised and mortality is hastened. To simplify this definition, I would say that when a person becomes old, gradually there is a decline in the reserve and function of his body. And this reduced reserve makes him little less able to cope with all kinds of stresses. And once this happens, we can say this individual is frail. Of course, there are methods to precisely measure frailty. I would be dealing with little later. This is a picture which shows a difference in the course of his life between an independent, non-frail individual on the upper part of the graph and a dependent, frail individual on the lower part of the graph. Frailty has a slow onset, but its progression may be quite rapid. It is triggered by diseases, malnutrition, lack of physical activity, any stressor that causes change in health status, and many other things that can trigger frailty. In the upper part of the graph, there is a person who is independent. He gets, for example, a stressor in the form of a minor illness. In this case, it is urinary tract infection or UTI. He gets some symptoms, gets sick for some days, and then returns to baseline, and the baseline is shown by green color, and you will notice that the baseline before and after this acute illness are same. So he has returned to normal state as he was previously before the onset of UTI. But in the lower part, the red line indicates that if a frail individual gets the similar kind of stress, what happens? He dips more deeply, he gets more symptoms, and likely to become more sick. And when he recovers from that minor illness, he is not able to return to his baseline, which was there previous to this illness. And that is what is the difference between independent and dependent people. Now, why frailty is important? Frailty has a potential to predict in any elderly individual about adverse health outcomes, recurrent falls and disabilities. It can also predict that this individual is vulnerable to recurrent hospitalizations, and it also indicates rather early mortality, and it also tells us that a frail individual will be less responsive to vaccine. The vaccine effectiveness is likely to be lesser in frail individuals. Secondly, the frailty assesses the risk for elderly persons who are either living in community or who have serious diseases and or those who are going to undergo surgery. So we know that before these happenings like serious diseases or undergoing surgery or during that time, we can find out how the risk of this elderly person is to undergo these procedures. Finally, Frailty is able to identify elderly people who are most likely to benefit from comprehensive geriatric assessment, which has a potential to unearth a health deficit or more than one health deficit in an individual, and therefore it will enable us to address this health deficit. And secondly, Frailty can identify elderly diabetics who require less stringent glycemic control, because such patients who are frail, they are liable to get hypoglycemia if strict control of diabetes is attempted. And finally, Frailty is also able to identify elderly hypertensive patients who are more vulnerable to side effects of pharmacotherapy for high blood pressure. So we're going to address 5 basic questions. How frequent is frailty? That is, what is the prevalence? What causes frailty? What are the 2 common tools to screen for frailty? And what is the importance of identifying this disease in elderly people? And how do we prevent and manage frailty? Coming to the prevalence of frailty. Prevalence, of course, varies widely across the world depending on different populations, different communities, different socioeconomic status, and so on. But it also varies according to the tool for screening that has been employed by the researcher. Overall, the Western figures indicate that 10% of people above the age of 65 are having frailty. Corresponding Indian figures are about 21%. Frailty is, of course, age related among the people and is more in females compared to males. 85 plus individuals are frail to the extent of 40 to 50%, while if we look for frailty in persons above 95, almost everyone will be found to meet the criteria of frailty. As far as the indoor patient figures are concerned, it was found to be 33% in 2008 from AIMS. And according to another study, when we try to find out the prevalence of frailty among patients belonging to different medical specialties, it was revealed that among cardiology patients, 10 to 60% were frail. Among nephrology patients, 37% of patients were frail. And among oncology or cancer patients, 42% were frail. Among HIV patients, 15% of patients were frail. And among those who were undergoing surgery, as many as 42 to 50% were found to be frail. What are the causes of frailty is the next question. There are multiple causes of frailty. Some of them are known, some of them are not so well known. But there are few which are often discussed and debated among the workers. First is role of chronic inflammatory state. Inflammation is indicated by high cytokines, high C-reactive protein, and high alpha tumor necrosis factor, and it is a part of aging process. And it is also a part of diseases like diabetes, hypertension, chronic obstructive pulmonary disease, coronary heart disease, chronic kidney disease, and so many other diseases. This inflammatory phenomenon contributes to frailty by reducing the reserve of many body systems like endocrine, musculoskeletal, CVS, and hematological systems. Immune activation, social isolation, depression, and lifestyle factors like obesity, smoking, and alcohol are also known to increase the chance of inflammation, and there are genetic influences. They also further promote frailty. High levels of inflammation is associated with catabolism of skeletal muscle, and that is how it contributes to frailty through sarcopenia, malnutrition, anorexia, and weight loss, all of which are a part of frailty. This is the second major group of causes of frailty, that is role of hormones. Reduced growth hormone, reduced insulin growth factor 1, reduced sex hormones and their precursors, together with raised cortisol, are a part of aging process and contribute to age-related muscle mass reduction, sarcopenia, frailty, and even sarcopenic obesity. Sex hormones like dehydroepiandrosterone sulfate and growth factors like IGF-1 or transforming growth factor beta are essential to skeletal muscle metabolism, and IGF-1 deficiency specifically negatively affects strength and walking speed. Thirdly, vitamin D deficiency is also known to impair muscle function, and it therefore contributes to falls, sarcopenia, poor function, disability, etc. This is the summary of what I said with regard to the causes of frailty. Risk factors are enumerated on the left side. Inflammation is suggestive of immune activation and inflammatory activation, already discussed. And the four systems that are indicated have also been alluded to. And the final result is a specific phenotype which compasses five parameters: weakness, weight loss, exhaustion, slow activity, and slowness. The biomarkers of the respective causes are given at the bottom of each rectangle. Now, there are so many diagnostic tools for the screening of frailty existing in the literature. I don't think I would be able to go through them for the lack of time, but I think there are two commonly used and more popular diagnostic tools which I would like to summarize before you. First is 5 items based, what is called frailty phenotype or FP, described by Frades in 2001. This has 5 items: mobility, strength, nutrition, energy, and physical activity. Mobility means a person, if he is unable to walk 4 meters in 6 seconds, it is slowness. Strength means if the person's grip strength is less than 12 kg in case of male or less than 7 kg in case of female, it is weakness. Nutrition is a weight loss of 4 kg or more the past 1 year, that is shrinkage. Energy means if a person has self-reported exhaustion for at least 3 to 4 days in a week, this is exhaustion. And physical activity means the person is not engaged in any weight-bearing activity, or he is sitting or lying for more than 6 hours in any 24 hour, means it's low physical activity. Sarcopenia is a very important feature in frailty, but according to resistance of any of these 5 items on screening an individual, we score for these items. We assign 1 point for each item. And if there are 3 or more positive items present in an individual, we label him as a frail. If there are 1 or 2 items which are present, we call this individual as pre-frail. And if there are no problems at all and none of the item is applicable to an individual, the score is 0 and we can call that individual as non-frail or robust. The next slide shows another diagnostic tool which is popular, very often employed, goes after the name of Rockwood, and it calculates what is called frailty index, described in 2005. And here 36 health deficits are found out in the patient. How many of them are present? This could be self-reported, this could be clinically or laboratory proved, doesn't matter. But these 36 items are listed below. You may not be able to read them. But on the left side in the green color, there are 20 disease states. On the right side, upper part, in the purple color, there are 8 symptoms, signs of geriatric syndrome. In the bottom right, there are green colored 7 deficits which go under the group of disability. And finally, in between, there is a laboratory value of anemia or hematinic deficiency, which is the 36th item. So what do? We try to find out in each individual who is being screened how many health deficits he has. And we divide the number of health deficits present in that individual by the possible total of 36 items and reach what is called frailty index. If there are 9 or more health deficits present in the individual, he is labeled as frail and his frailty index is calculated as 0.25. In a pre-frail individual, there are 4 to 8 health deficits present, and when they are divided by 36, the frailty index comes to 0.08 to 0.24. And lastly, in a non-frail individual, the health deficits are present only up to 3 or less, and in that case, the frailty index will be 0.08. There are several other diagnostic tools of frailty that I have already mentioned, but I think one I would like to mention in passing. This particular tool is biomarker based, and there are 40 deficits in biomarkers. The biomarkers are grouped under inflammatory, hematological, cellular, immunosenescence, and genetic epigenetic. Here also, in the similar manner, frailty index can be calculated by dividing the number of biomarker deficits by the possible total of 40. Now let us compare the significance of the two popular criteria which are often employed in the practice. One is the frailty, that is FP, and the other is rock weight, that is FI. Frailty phenotype is more widely used than frailty index, but the latter gives a higher prevalence of frailty. Frailty phenotype gives yes or no presence of frailty, as you said, by 5-item scoring, but frailty index can calculate the frailty as well, can grade the frailty as well. Frailty index is better than frailty phenotype for large epidemiological studies and for prediction of mortality. Frailty phenotype regards frailty as a syndrome distinct from disability and comorbidity, while frailty index does not do that. Frailty phenotype gives importance to each of its 5 criteria, but frailty index emphasizes on the cumulative effect of several health deficits. What is the importance of identifying frailty? To some extent, I have already described it, but very importantly, it also can predict the survival, the expected survival in people who are frail today versus people who are non-frail. This graph shows 10-year survival curve by the Rockwood criteria. The uppermost dotted line shows a survival curve which is slowly descending down, and the mean survival of these individuals who are non-frail is about 75 months from now. The middle line shows a survival curve which is relatively going down more steeply, and these are belonging to pre-frail individuals, and their expected survival is lesser, that is 64 months. And the lowermost line, which is a dark black line, belongs to mentally frail individuals where the survival curve is coming down rather steeply and their expected survival for the next 10 years is the least, that is 50 months. So that is the importance of identifying frailty. We now come to the last part of our presentation, that is about prevention and management, and I have tried to divide them into 5 pillars. First is comprehensive geriatric assessment, which identifies and detects certain health deficits so that these can be addressed properly by the healthcare provider. Second is about exercise. Third is about nutrition. Fourth is about managing comorbidities and polypharmacy, that is, person may be on several medications. And finally, the miscellaneous aspects. Please remember that this intervention can be multi-component also, that is, combining more than one pillar or addressing more than one deficit if they get detected by comprehensive geriatric assessment. This is the first pillar, as I said, CGA. CGA is able to detect physical, social, psychological, cognitive, environmental deficits, and also it is able to screen for activities of daily living. And for that, we have to have a good CGA team, which not only comprises of a physician, but also social workers, psychologists, dietitian, nurses, etc. This is pillar number 2, that is about exercises. The formula is go slow from step 1 to step 4 manner. On the bottom side, step 1 is flexing exercises. So begin with only flexing exercises, that is shoulder rolls, chest presses, and other warm-ups. This is a little mild exercise that I think a frail person can even stand up to. The second is balance exercises, be carried out on 2 or 3 days per week. These are for the kind like one leg raise, stand, or sit without hand support, etc. Third stage is resistance exercises. You can ask an individual climbing stairs, push-ups, chair stand, arm raise, biceps curl, etc. Again, about 2 to 3 days per week in the beginning. And finally, aerobic exercises. That means walking for 30 minutes per day or in episodes of 10 minutes thrice a day. Please also remember that if a person is non-frail and you are trying to prevent frailty, he can start from any side. He can even start from aerobic exercises. But this graded manner of exercises is mainly applicable to people who are already frail or pre-frail to some extent. And also please remember that all exercises should be under medical supervision and a watch on the pulse rate. This is the third pillar about nutrition. The hallmark is protein quantity, protein intake has to be there, which is often missing to this extent in our elderly population. The prescription demands an intake of 1.2 to 1.5 gram per kilogram, individualized, need-based. Vitamin D, 1000 international units daily. And among the proteins, one important specific thing is that leucine-rich essential amino acid is important. Supplements are available for that and they could be taken in between the meals. Nutrition and exercise when combined, which is a sort of multi-component intervention, it is known to improve gait speed, grip strength, activities of daily living, and even elevate the mood, as was described by Chatterjee in 2018. He also said nutrition plus exercise can convert even pre-frail to non-frail individual. That is something remarkable. This is the fourth pillar, preventing and managing comorbidities and polypharmacy. Well, not all existing morbidities have been shown in the picture, but there are many others. Some of them shown in the picture are cardiovascular disease, type 2 diabetes, etc., or dementia, cognitive decline. But there are many other comorbidities, but they all require proper management by the healthcare provider. And if there is a polypharmacy, I think the doctor has a duty to advise him how to reduce the medicine if possible and even attempt what is called de-prescribing. This is the last one, miscellaneous. Many are agreed upon, others are not agreed upon, some are in research stage. On the left side, I have enumerated testosterone only for those who are testosterone deficient. Safety issues are there. Both hormone prescription, anabolic steroids have been advocated by some. Sorry. And socialization is important because loneliness and social isolation is a risk factor for frailty. For females, estrogen in postmenopausal period is important. It is able to prevent sarcopenia. Insulin-like growth factors have been recommended sometimes, and uncommonly anti-inflammatory drugs or ACE inhibitors have also been advocated. And of course, if there is anemia, the patient needs to be treated for that because this is one of the health deficits I already described. So what is the take-home message? Comorbidities and disabilities are of course the hallmark in old age. But frailty is also one of the sinister three problems in old age. Control of comorbidity and disability can delay death, but frailty is irreversible and hastens death, and therefore it has to be detected early and addressed properly. Frailty is difficult to define, and it is difficult to distinguish from non-frail aged people, and for that reason there are so many tools existing in the literature, but the two common tools that I have said are able to reasonably define and distinguish from non-frail people, and these both tools are validated. High index of suspicion and routine screening are needed, and any standardized tool which is validated can be used to diagnose frailty, I have already told. Most importantly, comprehensive interdisciplinary geriatric screening is the first step for any suspected elderly, and it is the cornerstone of management. Exercise and nutrition are also important interventions, I've already told you. And with that, I thank you for hearing patiently. Thank you once again. I will stop sharing the screen and leave the meeting.